And so next week you won't really know anything about the case, and so it'll be a little bit more difficult. But I think it'll be more educational too. So okay, let's get started then. So we have a 78-year-old female that presents with progressive chest pain, shortness of breath over the last 1 to 2 weeks. She's alert and oriented to herself and to the day, but not to the place or situation. The daughter present assists with the history taking. So 2 weeks ago, she felt ill. She had a sore throat, congestion, and a slight cough. So Dr. Sanders, what do you make out of her having this sore throat, congestion, and a slight cough?
Immediately, I would sort of think it's indicative of maybe some sort of an infection, whether it be viral or bacterial, especially with the soreness of throat and the congestion.
Okay, and so is that going to be a upper respiratory infection or a lower respiratory infection?
I'm actually not sure. I guess judging by her x-rays, I would say lower respiratory, but I'm actually not sure.
Okay. So where do you know where the cutoff is between upper and lower?
I don't.
It's okay. So the lower respiratory infection is basically your lungs. So anything in the lungs is going to be lower. Anything above that's going to be upper. But usually when you have a sore throat, congestion, and the slight cough, plus or minus, but more so the sore throat and the congestion, it's more indicative of upper respiratory infection, meaning your ear, nose, and throat. A lot of times with these symptoms, it can progress to a lower respiratory infection, but not necessarily. So if you think of all the times you had a cold or a cough, it goes away on its own. Is there any cardiac thing that you can think of that can be caused by an upper respiratory infection?
Maybe something like pleurisy, so where she's coughing a lot, and so that sort of lining is getting inflamed, and she is really irritating that, and so it's causing that sort of chest pain.
Yeah, potentially. The pleurisy, for the inflammation of the pleura itself, the cough won't necessarily make that irritation. It would be more outside that you would have that those symptoms. So because of the muscles, not so much of the actual pleura itself. So Dr. Zainab, any cardiac thing that you can think of that can be caused by her upper respiratory infection?
Yeah, my first guess for that one would be pericarditis. Just because, again, like she mentioned before, like the lining rubbing against and causing that irritation that causes that cough. And then
Okay.
I also said that was because of like the sound that's coming from her chest area was muffled. So I think that there's definitely fluid in there.
Okay, so the pericarditis definitely can be caused by a upper respiratory viral infection. Now, do you know what virus typically causes pericarditis? Any virus can technically cause pericarditis, from what I remember, but there's one that typically does.
I do not. Let me ask my group really quick.
It's okay. If you have the answer, you can just put it in chat. But 1 week ago, so her symptoms improved, but 1 week ago she began feeling weak and began complaining of chest discomfort. And she was usually able to walk around the block daily, but she would tell her daughter she didn't want to because she was sleepy. And so, Dr. No, can you interpret that for me? Why is it that it's important to know she doesn't want to walk anymore?
So I don't really know what could explain why it makes her sleepy, but I think it mentions that she has shortness of breath, which could indicate some kind of lung problem, or even a chest problem, if there's chest pain involved.
Okay. So if she's having shortness of breath, then definitely a lung problem. if she's having shortness of breath but no pain, a lot of times that's indicative of something like congestive heart failure, where your fluid, your pump is no longer able to push that fluid forward, and so you're having a backup of fluid into the lungs. But if you're having chest pain with exercise, what would you be thinking of?
I'm sorry, could you repeat the question?
So if you were having, if let's say she didn't want to walk because she was having chest pain every time she walked, what would you be thinking of?
Maybe angina, because maybe there's some kind of sharp pain in her chest that could prevent her from walking.
Exactly. So it would sound more like a cardiac issue. For her, though, she's saying she's sleepy. She doesn't want to. More so than anything, that's for me. That was more of like an indication that she was not at her baseline. So something was going on with her. She said that 6 days ago she was up at night confused and could not sleep because of the cough. And so the confusion is another kind of something different from her baseline. So, but she has dementia. So how are you thinking about that, Dr. Villagomez? She has baseline dementia, but her daughter's saying she's confused. So how would you interpret that?
Well, I think that it's mostly due to the dementia, not necessarily relative to the chest pain.
Okay. But she's saying, the daughter's saying that she is usually pretty with it. She likes to walk. She does all her activities. If she's now more confused, is that because of her dementia, or what do you think?
Well, I think the change in behavior in regards to like her normal activities is probably due to the pain. But as for the confusion, I still think it's due to the dementia.
Yeah. So with dementia, you'll have a gradual decline in like cognitive function, but it's not acute. So if you're doing well here and then you suddenly drop, well, that's an acute change in the way that you're thinking and that your mentation. That's not caused by dementia. So you have an additional layer of confusion on top of the dementia that is indicative of something else going on. It can be really anything. It can be an infection, it can be a stroke, it can be really anything. So the whole reason why that's in there is to show that there is something going on. And when you guys see patients, it's going to be important to be able to pick out those subtleties, because it'll keep you from saying, oh, that's just her dementia. Okay. So let me see. So as she continued to cough, her chest pain worsened and her cough was non-productive. So Dr. Cornejo, what do you think about that statement? What do you think could potentially be causing that pain?
Well, she said that her pain got worse while coughing, which could be the pleural lining, but it could also be costochondritis because she is exacerbating those muscles, which would cause more inflammation, like in the cartilage of the sternum. Good.
So yeah, so it can be, the pain can be because of the pleura. If she has pleural inflammation, that can definitely cause pain. And like you said, if it's the muscles or the cartilage outside on the exterior of the chest wall, then that can definitely cause the pain too, causing costochondritis. Perfect. Do you know how you would treat costochondritis?
Yeah, I would do maybe some like ice on the chest, or I would prescribe like ibuprofen or something just to decrease the inflammation, and I would decrease any exercises she may be doing.
Perfect. Okay, so Dr. Sahil Patel, I tell you that her chest pain is located on the right lower side and radiates to the right arm. What can that be indicative of?
So this information kind of helped me narrow it down to something like a pericarditis or a pneumonia. Essentially that it's not just a localized pain and that it is radiating.
Okay. So what specifically about the radiations to the right shoulder? What can that tell you?
Um, yeah, I'm not really sure about that. I think that it could be something that has to do with the phrenic nerve. Not really
Yeah.
sure.
Yeah. So, what does the phrenic nerve do?
It has to do with motor, and it's a motor and sensory nerve originating from the spinal nerves in the neck.
Perfect. Okay.
I'm using
good.
my resources.
Good. That's super important. Use as many resources as you can. Okay, so Dr. Colton, why is it that she would have shoulder pain if we're thinking about the phrenic nerve?
I see here that pericarditis is going to be pain that radiates to the traps area, so that's where the phrenic nerve would be, right?
Yeah. So not so much because of the pericarditis, but in her case, it's more likely because there's irritation to the diaphragm. So the phrenic nerve travels and innervates the diaphragm, but it originates from the same nerve roots as nerves that come from that go to the right shoulder, and so it's referred pain because of that irritation. So if you guys think of for males, if they're hit in the testicles, they have abdominal pain because that's where the testicles originate from, and you have that referral of pain. So if you have diaphragmatic irritation, it can cause radiation to that right shoulder, and so it tells us that there might be something going on in that lower right chest area, and it might be involving the diaphragm. So good.
Gotcha.
Somebody on YouTube is asking, since it's not radiating to the left arm, can we rule out a heart attack? Dr. Parikh, can you take a stab at that question?
I don't think you necessarily can without looking at like the labs and everything, just because like you don't really know 100%, and like some people exhibit different symptoms when they have a heart attack, but like I'm not 100% sure.
Yeah. Good. So heart attack. Like I think I had mentioned in a video before, the studies that were run on to classify typical chest pain were run on people that were not indicative of the entire world population, and so in women and elderly patients especially, they can have symptoms of right chest pain, they can have shoulder pain, they can have neck pain, they can feel like they have a tightness around their throat, abdominal pain, and all of that can be indicative of a heart attack. And so you can't necessarily rule it out without getting labs and without getting a little bit more history. So good. Okay. So let me see. I said that her pain is sharp and stabbing. How does that help you, Dr. Nason? Or does that help you at all?
I mean, it helps to know that it's not aching, like it's not just a continuous pain, I guess. And like you said before, she has it mainly when she like exerts herself or when she's breathing heavily. So I think that's important to notice, but I don't know if it doesn't point you necessarily in the right direction anywhere. I feel like it maybe rules a few things out in terms of like long-term pain that just prolongs.
Yeah, and so what I would think about with that description of pain, it's not that typical pressure that people feel with a heart attack. So maybe lowering my differential for the heart attack, especially given that she doesn't have the whole picture of like exertional chest pain that gets better with rest. So, but you never want to just rule it out completely. But good. All right, and Dr. Astrid Perez. So I say that she is having more confusion and she's refusing to eat. So what do you make of that? Dr. Perez?
Yes.
Mm-hmm.
So I guess her confusion is related to her dementia.
Mm-hmm. What about her refusal to eat?
I wouldn't be too sure.
It's okay. So with her refusal to eat, so we can assume from here that she was eating before, right? And she was doing okay, and now she has this change where she's like, I don't even want to eat. And so if you think about all the times that you guys were really sick, you have a lot of times you have a lack of appetite, and so that change tells us again that there is something going on with her that is out of the normal. And with patients that have dementia, you have to find those little clues that will push you into deciding whether or not this patient is sick or not sick. And I think once you see more cases and when you get more experience with it, it's going to be a little bit easier. But you have to try to find those like differences from their norm that raise up your antenna to say, yeah, I wouldn't want to necessarily send this patient home with nothing. Does that make sense?
Yes.
Okay. All right. So, Dr. Evelyn, I give you her an ROS where I say she denies chills, nausea, vomiting, abdominal pain, hemoptysis, loss of consciousness, palpitation, and anosmia. So, out of all of those, what's the one that sticks out to you the most?
Can you repeat that one more time? I'm sorry.
So I give you that she denies chills, nausea, vomiting, abdominal pain, hemoptysis, loss of consciousness, palpitations, and anosmia. So out of all of those, is there any one that sticks out to you the most?
One of them is palpitations, because after that you can rule out, okay, so there's nothing wrong with their heart. So they're not having palpitations, they're not having so nothing is going on with there. Appetite, again, that's nothing too concerning. SOB might be because they're having shortness of breath and she's saying she can't walk the distance she can. Her body isn't able to handle that. So, but again, it can also be from age.
Okay.
But I'd say palpitations because I'm going with like ABCs, so heart.
Yeah. So with the palpitations, though, you can't necessarily say that it rules out a heart issue because you can also have like a heart attack without having palpitations. So it would tell us more that she might not have an arrhythmia. But good. So let me see here, Dr. Molina. Anything else stand out for you in the ROS?
Could you please repeat that?
Yeah, so she denies chills, nausea, vomiting, abdominal pain, hemoptysis, loss of consciousness, palpitation, and anosmia. So anything in there stand out for you in that negative ROS?
So, if she's denying having anosmia, I think it's indicative that she might one of the symptoms of COVID, I'm pretty sure, is loss of smell. So we can kind of look in that direction.
Yeah, so that's super important because the anosmia, every patient that I've seen that had anosmia recently had COVID. And so if you guys are working right now in the hospital or in a clinical setting, anybody with anosmia, be very careful, protect yourself. But yes, so we don't know enough about COVID to actually say these are the typical symptoms or not. And we've been seeing a lot of different symptoms. I saw a guy that came in, is a young guy that came in just with a blood clot and he was COVID positive. So we are still classifying what people have with COVID, but it's good to know that she doesn't have anosmia because that won't entirely rule out COVID, but it does help a little bit. Good. So, Dr. Sarah, anything else stand out to you?
The hemoptysis, the fact that she doesn't have that either. I feel like for chills and nausea and vomiting, those are symptoms that I've seen in a lot of conditions, but hemoptysis specifically was, I think, pneumonia. So the fact that she's not coughing up blood, I think that's also kind of points us in the right direction. Maybe pneumonia is a little less likely, but I wouldn't rule it out completely.
Yes. So you don't necessarily have to have hemoptysis with pneumonia. What was that? I don't know if somebody said something. But you don't necessarily have to have hemoptysis with pneumonia. You can with, I guess, very severe pneumonia. But Dr. Gist, Why did hemoptysis stand out to you?
I would say just because coughing up blood can be very like it could be like a serious condition in the lungs. And so I think it's good that she doesn't have it. That's what I was thinking.
Yeah. What would you be worried about if she did have hemoptysis?
Severe like bronchitis or severe pneumonia or even some certain cardiovascular condition.
Okay, so what cardiovascular condition would you think of?
Maybe something that has to do with a vessel being perforated or whatnot.
Okay, Dr. Villa Gomez, you said pulmonary embolism. So can you explain that a bit?
Well, the reason you'd be concerned if she's coughing up blood and being related to a pulmonary embolism would be that she'd have a clot somewhere in the lungs, and that could be causing the coughing up of blood.
Yeah. So what happens with the PE that causes like a coughing up blood? You're basically the clot is going and hitting a certain vessel that basically cuts off blood supply to that area of the lung, and so that area of the lung is actively dying. And so as that lung tissue is dying, you cause basically bleeding into the airways as well, and causing you to cough up that blood. Good. So Dr. Vietla, is there anything else that you think of when you think of hemoptysis?
I think another thing was cancer. They say like lung cancer, yeah, things like that is another thing that I thought of. And yeah.
So why lung cancer?
Because when you have like, buildup of like excess cells dividing, I think like your body can have it doesn't it like form in the lungs and kind of like I think with that they can erupt and also cause like a lot of damage to nearby cells, everything like that, and that can cause blood loss.
Yeah, so lung cancer is basically an abnormal growth of cells within the lung parenchyma, within the lung tissue itself. And so as it grows and divides, it can recruit more blood vessels to that mass. And so when it does that, a lot of times it grows out of control, and you have a bleeding inside the actual tumor itself. The other thing is that it can damage vessels as it grows out, and that can cause bleeding into the airways. And so that blood in the airways is an irritant, and you'll start coughing that up. Dr. Colton is saying that if cough was ruled non-productive, wouldn't hemoptysis be implied? And yeah, technically it would be implied. Okay, but it's just all for discussion. Okay, so good. And then the last thing is tuberculosis. I think Dr. Sanders mentioned TB, and people in the YouTube comments mentioned TB as well. So tuberculosis in the lungs can cause coughing up blood, and that's something that you always want to rule out if you have somebody coming in coughing up blood. So good. Somebody in the comments was saying that their grandfather has lung cancer, and one of the first symptoms were coughing up blood. And a lot of times that is what we see. Okay. So I mentioned that the patient lives at home with the daughter and son-in-law, and the son-in-law is going to work. Now, Dr. Lopez, any specific reason why that's important? Let's go to Dr. Mansi.
So I think it shows that she's dependent and that she can be exposed to different sicknesses from her family members.
Yeah, and so if her son's going to work, there's a potential exposure to COVID. So that's one thing. And I think I said that she was independent of her activities, daily living. So that's also very important. A lot of times that means that they are taking their own medication. So if they become more confused, they can either forget that they took their medication and take it again, or not take it at all. So good. Now, Dr. Slayton, is there anything in her medications that we would be worried about if she took too much of? go with Dr. Foster.
I'm actually not sure. I guess I forgot what medication was because I didn't write it down, but I would assume the one that she would use because I know that she had like the heart condition when she kind of had like plaque kind of building up. So yeah, so whatever medication she was using for that, like if she took too much of, I would assume like I would be worried about that one.
Yeah, literally any medication she's taking, if she takes too much of it, that can be a problem. So yeah, but what was that?
Sorry, this is Julia.
Hey, so just super quick, the glipizide actually is one that is used for diabetes that can cause confusion if she takes too much of it because her blood sugar will drop too low. But any of these honestly can be very dangerous if she takes too much of it. So Dr. Slayton, I give you her vitals. Her blood pressure is 158 over 93, heart rate's 110, respiratory rate is 24, temp is 100.5, and O2 sat's 93 on room air. So can you interpret those for me?
I'm not exactly sure like the full vitals, but I'd be worried about a pulmonary embolism, I think. Just because she's very tachycardic and she's running a slight fever.
Okay. So let's say let's go through them. So is her blood pressure normal?
No, I think it's really high.
Okay. Her heart rate, you said it was high. What about her respiratory rate?
I think that's relatively low.
It's high. So the upper limit of normal for the respiratory rate is 20. And then her temperature, does she have a fever or no?
It's really mild so far as.
But she technically does have a fever, right?
Yeah.
Okay.
Yeah.
And then her O2 sat is 93 on room air. Is that too high? Is it too low, or is it normal?
I think it's low because I think normal ranges are between 94 and 100. Right?
Yeah. So it depends on how old you are and your comorbidities. A lot of us younger people, if we had a O2 sat in like 95, technically that would be normal-ish, but we would be a little concerned that something else was going on because we usually are like 98, 99. People with COPD, when they're in the hospital, we want them to be between 88 and 92. But for her, she doesn't have that history, so 93 is actually a little low for her. Good. And so with all of these vitals, is there any like syndrome that you would think of that she has?
I'm thinking pulmonary embolism, but I'm not 100% sure.
The pulmonary embolism can definitely cause tachycardia, but let's see, Dr. Wu. Do you think of anything? Can you think of anything that would that these vitals will tell you as far as like the YouTube comments actually help you out? I don't know how to actually word it without giving it away. Have you?
Sorry, what were you gonna say?
No, go for it.
Okay. I would say that the low O2 saturation and the higher than normal respiratory rate would indicate that she's having trouble getting as much oxygen as she needs for the gas exchange. So I would say that that's indicating inflammation like pneumonia in the alveoli.
Good. That's actually really good. That's a good observation. Now, have you ever heard of systemic inflammatory response syndrome?
I think I've heard of it before, where the inflammation spreads into the bloodstream and it's beginning to affect like other tissues and affecting their ability to get oxygen as well.
Yeah. So have you heard of sepsis?
Yeah.
Okay. So SIRS is basically sepsis without a source. So it has a very specific definition. So you if you have 2 out of the 4 criteria, you qualify for SIRS. And so if you have an elevated heart rate, an elevated respiratory rate, an elevated temperature, and an elevated white count, so 2 out of those 4 would qualify you for SIRS. And so if you have that syndrome and you also have a source of a possible infection, then you have sepsis. And so with her vitals, she has an elevated heart rate. She has an elevated respiratory rate. Her temp is elevated. So she qualifies for 3 out of the 4 right there. And so if we find a source, we can say that she's septic. Does that make sense?
Yeah.
Okay, good. So Dr. Ali Khan, anything in her head, ears, nose, and throat exam that stands out to you?
I think the only problem that we noticed was with the lungs, the chest. How if you looked at her X-ray, it had like a hazy part on her right lung, on the lower part.
And so what do you hear on exam?
So when we it says that when we did the exam, we heard the tacky noise, which you could compare to the friction of to 1 second.
It's okay. So the crackles actually
Paralytic chest pain.
So the crackles actually in the lung exam tell us that there is something inside the actual lung tissue itself. So a lot of times crackles happen because there's fluid in the alveoli, and so as it reinflates, you hear this crackling type sound. And so that tells us that in that lung area, there's probably something going on that's causing either fluid buildup or pus or something like that. So a lot of people were saying that this might be pneumonia. So pneumonia really does fit with that, that picture. Good. So Dr. Mohammed, what about the tacky mucous membranes? What does that mean?
I'm pretty sure I'm thinking Mooch might be dehydrated.
Yeah, good. So anything in the labs also correlate with that dehydration?
I'm not sure.
Okay, that's okay. Dr. Lien, anything in the labs correlate with the dehydration?
I'm not seeing anything so far, but maybe it has to do like her loss of appetite that was mentioned earlier.
Yeah, that can cause dehydration. But in the labs, I think in the comments, people are helping you out. Anything in the labs that can cause that is indicative of dehydration.
She has a low sodium level. High. High chromium levels or creatine?
The creatinine, yeah.
Creatinine.
So creatinine is something that's excreted by the kidney, and we use it to determine how the kidney is functioning. So she has a history of chronic kidney disease. So Dr. Karina Ray, if she has a chronic kidney disease, she's going to have an elevated creatinine anyway. So why does it matter? Why are we saying that she might be dehydrated?
Her dehydration could also be causing other problems, like in the heart, that would be it would show more because she already does have a kidney problem.
Okay. So her creatinine is 1.8 and her baseline is 1.1. So is that a significant change from her baseline?
I don't think it is. I don't really know the.
Okay. It's okay. So I believe, I have to look back and see, any change above 30% is indicative of acute kidney injury. So for her, if her baseline, if you draw her blood at any random time when she's feeling okay, her creatinine is about 1.1, and now it's 1.8, which would be more than 30%. And so because there is a change, yes, she has chronic kidney disease, but there's also something on top of that that is causing the kidney to function a little worse. A lot of times, especially with patients that come in because of another illness, it's because of dehydration, and all you have to do is give a little bit of fluids and it gets better. So good. So Dr. Ethan, anything in the CBC stand out to you?
Could you repeat the question?
Anything in the complete blood count?
Complete blood count. Okay.
Yeah.
So her white blood count is pretty high. Her hemoglobin is all right, but and her platelets they're in the normal range, but they're still on the high end. So a lot of this indicates that some sort of infection.
Okay, good. So, is it always infection if you have white blood cell count like that?
Sorry, yeah, I just corrected myself. It's not always infection, but it generally indicates some sort of inflammation.
Perfect. So yeah, some sort of inflammation. A lot of times it is infection, in all honesty, but the day that you think that it's just an infection is the day that somebody with an autoimmune disorder is going to come in and correct you. So always think of it as like as an inflammatory process, and then you can narrow it down to infection afterwards if you find a source. So good. Now let's go to Dr. Kailisha. Anything in the so we already talked about the creatinine. So what about the troponin?
For the troponin.
Kailisha, sorry. I apologize if I mispronounced your name.
Oh no, that's fine. I think for troponin, we saw that it was slightly elevated, and when I saw that, my first thought was maybe like an MI or something, but because I think her history showed that she wasn't experiencing progressively worsening pain, I think we kind of ruled out the MI.
Okay, good. And so she has a history of coronary artery disease. So if she came in with a troponin of 0.07, but her symptoms aren't kind of indicative of like chest pain because of the heart attack, can you just say like, yeah, it's probably not, and leave it at that?
Well, I think we probably have to do further studies, given the fact that she's had 2 stenting previously.
Good.
But since it's not severely like worsening, like increasing levels of troponin, then I don't think it's like kind of like an immediate STEMI or anything.
Yeah. So a few points there. So this the thought of the STEMI is a good one because if I had a lady with a history of coronary artery disease, even if her picture is not sounding like a heart attack, I'm going to get an EKG because I want to make sure that this is not an early heart attack and is not an early STEMI. And so I would get and the troponins are just not elevating at that point because I believe it takes about 4 hours for the troponin to actually show up in the bloodstream. So I would definitely do an EKG, just like somebody on YouTube had mentioned. What else can you do to make sure that this is not a heart attack?
Could you get like maybe some kind of imaging?
You can. So most of the imaging, though, so if you're thinking like an angiogram of the coronary arteries, you can do that, but they won't do it if they don't think it's a heart attack. But what about labs? She had a troponin and it's a little elevated. What would you do?
I'm not too sure.
It's okay. Let's see. Dr. Alex, anything that you would want to do with that troponin?
Want to look for maybe like an echogram just to see if there's any abnormalities with the heart there.
So yeah, so if you get an echo, I wouldn't necessarily get an echo on this patient, but if you were to get an echo and it was a heart attack, you would maybe see the as the heart beats, that wall of muscle is not beating very well because it's basically not working because there's no blood going to it. So good. Now somebody in YouTube is saying test every 2 hours. Would you consider doing that as far as like getting the repeat test every 2 hours?
Yeah, I would check to see the troponin levels, just to see if they go up or down, because if they go up significantly, then it could point to a heart attack or MI or something like that.
Good, exactly. So if they go up, then yeah, this might be a heart attack, and you better go take them to the cath lab. But I wouldn't necessarily do it every 2 hours. I would probably do every 6 hours. So Good. Now for I think there was somebody else had mentioned something. And then yeah, so if you think that this is a heart attack, a STEMI, you have to take them to the cath lab to get them stented. Good. Now in this case, because she has signs and symptoms of something else, and it's not it doesn't sound like a cardiac issue. The troponin is a little elevated, probably because of demand ischemia. It's not so much like the heart is actively dying because there's a blockage, and so you're having that release of troponin. More likely, she has a narrowing of her vessels at baseline, and because of this potential infection, she has decreased perfusion to those areas of the heart, and the heart is also working a little bit harder, causing more demand, and so you end up getting demand ischemia because of everything else that's going on, not so much because of the actual because of an actual heart attack. Dr. Ali Khan is asking, isn't it because of her kidney disease as well? And yes, troponin is cleared by the kidneys, but a lot of times, if you have an AKI, it can clear a little bit more slowly. So that might be a potential factor into it. But we would see elevated troponins at baseline for people that have like a higher stages of chronic kidney disease. Sorry. Okay. So, all right, and then the X-ray, Dr. Saif, can you interpret what you saw in the X-ray?
I'm not quite sure how to read an X-ray, but oh wait, am I the right person?
Yeah.
Okay.
So what did you see?
I saw, I mean, it's kind of murky. I'm not sure if that's like an indication of anything. The heart might be slightly enlarged, but again, I don't know what the normal is. So
Yeah, so on the X-ray, the easiest way to read one is to look to see if there are any if there's any asymmetry. So when you're not really trained to read X-rays, it can be very difficult, but for the most part, asymmetry will help you out. So on the right side, on the lower side of the X-ray, you see kind of this hazy area, and you don't see that on the left side. And so you can safely assume that there's something going on in that area. As you look at this more, you can you'll see that that it looks very similar to a pneumonia. So for this patient, she actually ended up having a pneumonia. And Dr. Colton, if she has it, would you admit this patient first of all?
I would say yes, just with all the like elevated labs and things we've seen, at least for observation, like rather be safe than sorry.
Is there a specific reason why she has to be admitted?
If anything, I would say maybe like the tachycardia.
So her vitals, yeah, good.
Yeah.
So her vitals show that she meets sepsis criteria. So she is septic, and so we push fluids, and we want to give IV antibiotics at first until she gets better. Good. Now, Dr. Chima, with her overall picture, let's say it is a pneumonia. We're going to treat her with antibiotics, but is there anything that we would have to know in order to choose the antibiotics to give her?
Maybe you'd have to know how it would interact with her other medications she's already taking, and also maybe what she's allergic to. And we know that she's not allergic to anything, if I'm not wrong.
Good. Yeah, perfect. So you would have to know that, but there's a classification between a community-acquired pneumonia and a aspiration pneumonia, and then a hospital-acquired pneumonia. What type of pneumonia do you think she has? And this is a harder question, so it's okay if you don't know.
I honestly don't know, but I'm gonna go with a community-acquired pneumonia because, as it was mentioned, that her son-in-law also goes out and works. So she probably has a higher chance, and due to her age, she probably has a higher chance of getting something like that from outside.
Good. So yeah, most likely this is probably community acquired, but she also has dementia. She's also alone by herself a lot, and she's been more confused. So it's possible she aspirated as well. So with an aspiration pneumonia, when you're eating or drinking something and it goes down the wrong pipe, so it goes into your lungs, you are introducing the bacteria that is in your mouth into the lungs themselves, and so that can cause a pneumonia, and that determines what type of antibiotics we give. So somebody on YouTube is saying most likely community acquired, which is treated with broad spectrum antibiotics such as erythromycin and ampicillin. I would probably, in a patient that's septic and coming in, I would probably give them something like ceftriaxone. It has broader coverage, and then you can also consider azithromycin because it covers atypical infections. But Dr. Fatima, you're asking about sputum testing. Why would you want to get sputum testing?
Because sputum testing is basically cultured microorganisms and to see the source of the infection, if it was viral or bacterial, that we would go with the correct antibiotics.
Good. So you can definitely get a sputum test. I can tell you now, a lot of times sputum tests come back and it shows mouth flora or it shows mixed flora. So it's not super helpful unless the patient isn't getting better. If they can produce some sputum, it's always good to try. But for the regular old pneumonia, you don't necessarily have to. You can just treat empirically and see if they get better. You'll also test some blood cultures, and if the blood cultures are positive, that's a whole other treatment algorithm, but that can also help as well. So Dr. Villagomez is asking, would urine testing also work? It wouldn't work for a pneumonia, but there is a urine test to check for Legionella and strep pneumo, so that actually might work. I've only seen, out of all the times I've ordered the urine strep pneumo, I think it's only come positive once. So who knows how actually helpful that is, but good. Now, there are a few questions. If it's a viral pneumonia, would the infection go away with antibiotics? It would not. The one thing that we can give if it's a viral infection, and actually, Dr. Giss, is there anything that we can give that would make the pneumonia get better if it was a viral pneumonia and she's not getting better initially?
If she's not getting better initially, I would say that it may have turned into like a secondary bacterial infection, possibly.
Good. So let's say it's not a secondary bacterial infection. Let's say she has COVID and she is getting worse. What can you give her?
Antivirals, possibly?
Antivirals is one of them, but specifically the remdesivir. But what else can you give?
I'm not positive on what.
That's okay. It's a hard question. Anybody else here know? You can call it out if you do.
Maybe
Dr. Cole, what was that?
Tamiflu, maybe.
Tamiflu if it was influenza. Dr. Colton, why did you say prednisone?
Wouldn't that reduce inflammation, especially like in the airways?
So how do people with pneumonia die?
Asphyxiation, maybe? I don't know.
They die because ARDS. So in ARDS, it's acute respiratory distress syndrome. And so with ARDS, you have your own body is reacting to the infection. And so when it reacts to the infection, it sometimes does it in a dramatic way that is way more than is needed. And so you start to have inflammation within the lungs, and all of those blood vessels and capillaries start to dilate. So once they dilate, they become more leaky, and so fluid starts to seep into the airways, and so you're basically drowning yourself. And so one way to stop that inflammation is to give steroids. And so you would give prednisone, or you would give something like solumedrol, which is another type of steroid. So good. Okay, and then would NSAIDs work to prevent autoimmune response? NSAIDs, I probably wouldn't do. I would do NSAIDs for something like a pericarditis, but not so much. Yeah, not so much for a ARDS picture. Okay, so there were a few other questions in here. Why did she have no palpable lymphadenopathy if she had an infection? So it's probably because lymphadenopathy in the neck is because you have some type of infection in the head and neck, and that infection is draining down into the heart area. And so if you have an infection in the lungs, that drains in the intrathoracic lymph nodes, and so you can't really feel those. There's a lot of times that you have an infection that you don't have any adenopathy, and adenopathy is just one sign of an infection. I think there was a question also about getting the CKMB. The CKMB is a test that we can get for a heart attack. We used to get that a lot, but not anymore because it's not as specific to a heart attack. It can be excreted by other injuries as well. And so, and then the time that the CKMB goes up is different from the time that the troponin goes up. So the troponin is actually more specific to the heart, and that's why we get the troponin over the CKMB now. When was the patient diagnosed with diabetes? Can this make the pneumonia worse? Okay, Dr. Shea, can you explain what you're thinking there?
I was thinking that her being diagnosed with diabetes can possibly make it harder for her body to fight off the pneumonia and the infection that she had previously.
Good.
So that can kind of make it worse.
Yeah, so when patients have uncontrolled diabetes, they are kind of in an immunosuppressed state. And so, especially if it's very high, if you think about it, you're having more sugar available for bacteria to grow. So they can sometimes grow more quickly and more aggressively because of that. But the overall immune status is like slightly immunosuppressed, so they can have a harder time fighting infection. So that's a really good point. I thought crackling was specific to a pneumothorax. Not really. So pneumothorax is when you have air built up between the lung and the chest wall. And so you would typically hear faint breath sounds because there's more space between the lung and the chest wall. And so that sound is not really transmitting very well. Additionally, if you tap on the chest, it'll sound more hollow. If it had been an MI, could you have hooked her up to a Holter monitor? So Holter monitor is going to test to see how the rhythm, to look for arrhythmias. And so sometimes with a myocardial infarction, so one of the more common ways that people die from an MI is from an arrhythmia, specifically ventricular fibrillation. And so you can hook them up to a Holter monitor. I know a lot of times we won't unless we see something on the telemetry while they're in the hospital. Holter monitors are typically monitors that they are sent home with, so they can monitor their heart rate at home. So I hope that answers your question. Dr. Wu is asking, would hospitalization put her at increased risk for opportunistic infections at her age and her immunosuppressed state? Dr. Al-Janabi, do you want to take a stab at that question?
I'm sorry, can you repeat the question?
Yeah, so Dr. Wu is asking, could hospitalization put her at increased risk for opportunistic infections at her age and in her immunosuppressed state?
I think it's more important to think of like the potential of her symptoms not getting better, especially with her meeting the having her pulse, the vitals are too high.
Yeah,
I think it's more important to hospitalize her and see if like her problems or like the infection gets worse.
Yeah, so it's important to hospitalize her definitely because of the sepsis. Hospitalization for anybody puts them at an increased risk for getting a secondary infection from the hospital. So yes, it definitely can do that. You are put at risk, but you have to weigh the risks and benefits. And for her, the risk of her going home is higher than the risk of her being in the hospital. So she would benefit from being in the hospital. And a lot of times the hospitals have very good cleaning protocols, and so that minimizes the risk. But hospitals are inherently dirty places because there's a lot of people that are sick there. So you always have to be careful. Let me see. Can the right arm pain be from type 2 diabetes and pneumonia amplifying the pain? I don't know if it could be from type 2 diabetes. I don't know if there's a mechanism for that. I can try to look it up. I don't think so. And pneumonia amplifying the pain. I think the right arm pain was more so because the diaphragm was irritated from having that inflammation in that area. The actual X-ray, this is not the patient's X-ray, but the actual X-ray had the pneumonia looked a little bit lower. And so it looked like it was actually at the level of the diaphragm. Have I ever used phage therapy to treat strep pneumo? I actually don't know what phage therapy is. So if you want to send that to me, Fatima, that'd be great. And I can always look back into it and look into it as well. Let me see. If we had gotten an EKG, would it help in the diagnosis of pneumonia? What would we have seen that would be indicative? So, so Dr. Muhammad's asking if the EKG will help with the diagnosis of pneumonia. It wouldn't necessarily, but it'll help us rule out some of the other causes of chest pain. And then how could this develop pericarditis? So that viral infection that happened before it can be the cause of the pericarditis, not so much the pneumonia itself. I had asked before, like, what is a typical virus that can cause pericarditis? And from my experience, Coxsackie virus has been the one that causes pericarditis, but I know that other viruses can cause it as well. So I probably have another like 2 or 3 minutes to answer questions before I have to take on the next class. And if I don't get to your question, just put it in the classroom and I can look through in the stream and I can answer there. Could the pneumonia, since she's septic, have caused a secondary pleurisy? Definitely it can, due to the pain while breathing and relief and leaning forward, which I would assume alleviates friction rub. So the leaning forward would alleviate more of a pericardial pain, but the pneumonia, because there's inflammation at the level of pleura, can cause pleurisy. Oh, phage therapy is a virus attacking a bacteria causing infection. I've never used that before, but that'd be interesting to read into. Can the 93% O2 be considered really low since the normal is 95? So yeah, it is considered low, especially if she's never had any breathing problems before. It doesn't put her at risk of COPD. A lot of times COPD is caused by a smoking history. Can pulmonary embolism be ruled out because of the fluid in the lungs? It can't be ruled out because you can have inflammation, but the chest x-ray is more indicative of a pneumonia as opposed to pulmonary embolism. The other thing that you want to look at is to see what her risk is of having a pulmonary embolism. And I think I posted a video yesterday about pulmonary causes of chest pain, and one of them is pulmonary embolism. And I talked about the Wells criteria, where it helps you decide what tests you need to do to check to see if to check what testing you would want. But because her symptoms don't really fit a PE, her chest pain was more gradual. It wasn't sudden onset. She was tachycardic, but she also had other signs of an infection, and she didn't really have any leg swelling. The pulmonary embolism is a lot lower in the differential. Okay, so any last questions? If not, I will let you guys go, and I can answer any additional questions in the stream. Okay. I hope that this was informational and you guys had fun kind of going through the case. Next week, it's going to be a little bit different because you're not going to know anything about the case. So you're going to have to be thinking about the questions you want to ask these patients. All right. All right, guys. You guys have a good day. You guys stay safe.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.
Bye.
Thank you.